half of the patients with heart failure have preserved global systolic function. In these patients with normal ejection fraction, heart failure is caused by left ventricular diastolic dysfunction. These patients have heart failure with preserved ejection fraction, HFpEF. Now, this is an example from a 55-year-old patient. Okay, let me go here. On the left, we have a 4-chamber view with a normal left ventricle, a normal volume, it's 94 milliliters, normal ejection fraction and wall motion, ejection fraction is 65%. We have also severe dilatation of both atria, as you see here. In the middle, we have a pulse Doppler mitral valve flow tracing, which from the same patient, with a classical restrictive phenotype, a high peaking E wave with almost 100 centimeters per second peak velocity, a shortened deceleration time below 160 milliseconds, which is the cutoff, it's 140 milliseconds, and then we have a very small A wave such that the EA ratio is well above 2. And on the left, we have another typical pulmonary venous flow, pulse Doppler pulmonary venous flow tracing with a very small systolic wave, which is consistent with the dilated atria and high pressures in the atrium, and a high peaking diastolic wave, which is simultaneous with the transmitral E wave. This allows us to diagnose high filling pressures and a restrictive cardiomyopathy. So it's a restrictive cardiomyopathy with normal anatomy of the left ventricle and normal systolic function, severe diastolic dysfunction. So this is a grade 3 diastolic dysfunction, also known as restrictive filling. And we also have secondary moderate pulmonary hypertension. Now, the analysis of diastolic function is the cornerstone of a diagnosis of heart failure with preserved ejection fraction. So this is an example of why you need to understand and analyze left ventricular diastolic function in your routine echocardiographic examination. Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to understand how to perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics we all have to engage with in daily practice: valvulopathies, cardiomyopathies, systolic and diastolic function, and also new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in echocardiography, and I will guide you through talks and clinical cases from my clinical experience, addressing a wide range of echocardiography topics. My imaging, the images that you will see, are based in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is also a website, echobyweb.com, where you will find much of the materials I will present in this channel. So let's have a look. This is the homepage. Up here in About, you will find my credentials. And then we have Atlas, 2 atlases, which is work in progress by now. Transthoracic and transesophageal, here are different chapters. In Ecolab, you will find normal values for echocardiography, scores like the Wilkins scores, analysis and quantification of the left ventricle, the mitral valve, the Montgomery plaque classification, for example. And then you will find formulas and calculations, guidelines, references, a complete echocardiographic, an example of a complete echocardiographic examination. And online calculators. Here I have created Excel spreadsheets that you can use on the website with calculations for echocardiography, evaluation of diastolic function, and based on the 2016 guidelines, and based on the European guidelines, indications for surgery or transcatheter therapy for the different valves, aortic, mitral, and tricuspid. For example, the calculator here for diastolic function, if you scroll down, is here. Okay, so in this window, which you can use if you fill up the yellow fields, like for example ejection fraction, the 2D echocardiographic examination, various measurements like mitral valve, tissue Doppler, etc. The Excel spreadsheet will give you, based on the variables that you input as output, the filling pressures, estimated filling pressures, and diastolic function class. In here, you can see the QR code to access the Echo by Web site, for example, for your cell phone right away. The topic of these series of talks, which span over 6 videos, is the echocardiographic analysis of left ventricular diastolic function and dysfunction as seen in the real world. It is a fast, synthetic, basic approach to this topic, which is quite large, and I will provide further on more detailed, a large video with a more in-depth approach. Now, these talks assume that you have a basic understanding on how to perform pulse Doppler and continuous wave Doppler interrogation of intracardiac flow, and also how to use tissue Doppler, myocardial tissue Doppler. And it is also assumed that you know how to perform basic echocardiographic measurements. However, you will find in the website echobyweb.com, I've just mentioned it, a large quantity of material, educational materials to address these topics. This is an outline of the 6 talks on the analysis, the echocardiographic analysis of left ventricular diastolic function and dysfunction. So the first talk will look at definitions of diastolic function, diastology, and its clinical utility, the utility of the echocardiographic analysis. And then there will be a basic presentation of the physiopathology of left ventricular diastolic function. In the second video, we will look at how to estimate left ventricular filling pressures with echocardiography, and we will look at the current recommendations, the 2016 and the 2025 latest recommendations on the analysis, the echocardiographic analysis of LV diastolic function. The third video, we will see a complementary analysis which is based on the assessment with echocardiography of pulmonary diastolic pressure, and then we will see how to estimate LV relaxation and compliance with echocardiography. The fourth video will all be about how to grade with echocardiography diastolic dysfunctions. The fifth video will be on how to report with echocardiography diastolic function and dysfunction, and we will see a series of clinical cases. In the sixth video, we will address the problem of sinus tachycardia and how to solve it, so to perform the analysis also with a fast heart rate. Then we will look on how and why to perform the Valsalva Maneuver. We will look at specific patient populations and see the conclusions. This is video number 1, from definitions and clinical utility of echocardiography to physiopathology. So, what is diastolic function? It is the left ventricle's ability to accommodate an adequate filling volume to produce the requested stroke volume while maintaining a low filling pressure. By contrast, systolic function is defined as the capacity of the ventricle to generate a cardiac output which is adequate to the metabolic necessities of the body. The pressure with which the left ventricle fills is a fundamental parameter in cardiology. and we can analyze that with echocardiography. Clinically, the filling pressure is linked to the patient's symptoms, dyspnea. Diagnostically, it is linked to heart failure, and therapeutically, it is linked to the response to therapy. So echocardiography has a role in all the diagnosis and follow-up of the patient. One of the main goals of treatment for heart failure is to reduce the filling pressures. For example, with diuretics. Therefore, low filling pressures, 12 to 15 millimeters of mercury depending on cutoffs in the literature, are good. High pressures are bad. And indeed, the main clinical consequence of diastolic dysfunction of any cause is the increase in left ventricular filling pressure. And what is diastology? It is the science that characterizes the diastolic properties, pressures, and filling patterns of the left ventricle and their clinical application, and includes the complementary estimation of the two main LV diastolic properties, which, as said, are relaxation, myocardial relaxation, and chamber compliance, or its reciprocal stiffness, and the left ventricular filling pressures. We say estimating and not measuring the determinants and filling pressures because we use echocardiography, which is a non-invasive methodology, and so we do not directly measure intracavitary pressures, from which the various diastolic properties, relaxation and compliance, can be calculated. However, today we have echocardiographic tools that allow us to make reliable estimates based on a large number of studies published since the 90s. These estimates that we perform play an important role for the diagnosis of myocardial diseases, therapy, assessment of therapy, and follow-up of the patient with therapy, and also for prognostic stratification. One very important thing to keep in mind right from the start is that the two main diastolic properties of the left ventricular chamber, that is relaxation and compliance, or stiffness, which is the reciprocal of compliance, are radically different. They act at different times during diastole, and both are fundamental and synergistic in determining a normal filling pressure and normal diastolic function of the ventricle, that is, to keep low filling pressures. Relaxation is an active, energy-dependent property, which is like the other side of the same coin with contractility, which is also energy-dependent. And this relaxation determines filling in this first third of diastole. We will see that afterwards. While compliance here is a passive property of the chamber, left ventricular chamber, that determines filling during the subsequent 2/3 of diastole, of filling. So the term diastolic dysfunction is inherently very generic and non-specific. It doesn't tell us what the primary problem is when we have dysfunction. So whether the dysfunction is due to relaxation, or if the diastolic dysfunction is due to chamber compliance or stiffness. And that is important to know for the purpose of diagnosis. It is preferable to always specify whether we are diagnosing a prevalent dysfunction of relaxation, for example, in the context of acute or chronic ischemia, or a prevalent dysfunction of compliance, for example, in the context of a restrictive cardiomyopathy, a heart failure with preserved systolic function. It is also important to understand that the two types of dysfunction, relaxation and altered compliance, often coexist to varying degrees, as we will see shortly. Finally, modern diastology cannot ignore atrial systolic and atrial diastolic function, which must always be described and taken into consideration. But this is a topic of a separate video, a quite complicated topic. If we fail to provide all this information, we will not provide an adequate, non-invasive hemodynamic assessment with our echocardiographic examination, and we will not exploit the full potential of modern echocardiography. Finally, it is equally important to understand that the cardiologist or sonographer must be familiar with the basics of cardiac pathophysiology, myocardial relaxation, Starling's law, the pressure volume loops, myocardial elastance, and so on. All concepts that we will refer to in this and the next video, and that are or will be detailed in separate videos in this channel. What else does this chart here tell us? In physiopathology, the main difference between systole and diastole is that the analysis of systolic function up here is easier. There is only one main determinant, contractility, which determines systolic function, in our case, ejection fraction. Whereas in diastole, when you analyze diastolic function, you have two independent main determinants of diastolic function. So analysis is quite difficult because the two determinants interact. Also, contractility and relaxations are closely connected because they are like two sides, as I said, of the same coin. Both are energy ATP dependent. Systolic and diastolic function both contribute to LV output, and a reduced cardiac output is mainly caused by reduced systolic function, whereas pulmonary congestion is mainly caused by alterations of the diastolic properties. One of the fields where the echocardiographic analysis of diastolic function is a mainstay is heart failure, especially what years ago we called diastolic heart failure, and we define today as heart failure with preserved ejection fraction here. Since the first European guidelines on heart failure, on this condition, which accounts for at least 50% of the cases, the three diagnostic criteria included evidence of abnormal or prolonged left ventricular relaxation and abnormally reduced LV compliance. The other two criteria were normal ejection fraction, previously also mildly reduced when we were talking about diastolic heart failure, and signs, of course, signs and symptoms, clinical signs of typical heart failure, which of course were intended to be evidence of increased left ventricular filling pressures. So based on these early guidelines, were in the 90s, cardiac catheterization was no longer necessary to measure relaxation or calculate diastolic compliance. From then on, non-invasive echocardiography was deemed sufficient, and this was very important because this boosted diastology and the use of echocardiography. Catheterization is now today reserved for specific and complex situations such as differential diagnosis between constrictive pericarditis and cardiomyopathy, or to complete a diagnosis of a phenotype of restrictive cardiomyopathy. HFpEF was previously known as diastolic heart failure because we thought that systolic function was completely normal. But today we know that also systolic dysfunction is involved to a certain degree because today the analysis of a strain, systolic strain, which studies subclinical systolic dysfunction when ejection fraction is normal. So strain shows that in these conditions usually EF is normal, but strain is abnormal. So longitudinal systolic function is almost always involved. As we have seen in the previous slide, contractility and relaxation are both ATP energy dependent and respond to the same pathogenic agents. So dysfunction is of contractility and relaxation are usually interconnected. As we have seen in a previous slide, contractility and relaxation are both ATP dependent, energy dependent, the same mechanism, and respond so usually to the same pathogenetic agents. So dysfunction of left ventricular relaxation and contractility are often interconnected. But what determines the determinants? So relaxation and chamber compliance, that here I'm showing as the reciprocal chamber stiffness. We have just said that LV relaxation and compliance are determined by radically different mechanisms: active mechanism relaxation and passive mechanism chamber compliance. As you can see here, the anatomical and functional substrates that influence the two diastolic determinants are also different. For example, an increase in left ventricular afterload, as in arterial hypertension or aortic stenosis, prolongs LV relaxation, but also asynchrony, like in abnormal wall motion, myocardial ischemia, or dysynchrony, like in left bundle branch block, they all prolong, have an abnormal effect and prolong LV relaxation. Whereas typically the presence of myocardial fibrosis tends to increase chamber stiffness or reduce compliance. It should be remembered, ventricular hypertrophy tends to both prolong relaxation, and when moderate to severe tends to increase chamber stiffness. It should be remembered also that both myocardial ischemia and ventricular remodeling in general tend to influence ventricular relaxation before it influences contractility. So both relaxation and chamber compliance or stiffness determine diastolic function, but in the time domain, typically relaxation is prolonged, so is abnormal before there is a reduction in chamber compliance. However, not everything is so straightforward. For example, in acute prolonged ischemia, as in a patient which comes in the ER with a prolonged angina, or during myocardial infarction, or during, for example, balloon inflation during PTCA, these situations will all produce both simultaneously marked prolonged relaxation and increase in chamber stiffness. Okay, now let's look at the clinical phases of left ventricular diastole. This is basic knowledge, it must absolutely be known. So unlike systole, which recognizes two phases, isovolumic contraction and the ejection phase, diastole recognizes four phases. You can see here in yellow, isovolumic relaxation, in green, early rapid filling, then we have in orange diastasis, and then we have atrial filling caused by atrial contraction in red. The first phase is known as isovolumic relaxation because it occurs in the absence of changes of left ventricular volume, as you can see here. In yellow in the graph. It begins, so isovolumic relaxation begins with aortic contraction here and ends with mitral valve opening. It is characterized by a very rapid decrease in ventricular pressure, which is caused by myocardial relaxation. And the speed at which the pressure decreases quantifies LV relaxation as physiologically normal or rapid, or pathologically slow. During this phase, there is also a very small increase in atrial pressure. Then we have the second phase, green one, early rapid filling, which in green in a graph, which begins with mitral valve opening and ends with the end after the first third approximately of diastole, with the end of rapid filling of the ventricle. During this phase, we must remember that LV relaxation spans the whole isovolumic relaxation and early rapid filling. Here we have the decrease in ventricular pressure. When ventricular pressure decreasing crosses atrial pressure and falls below atrial pressure, we have mitral valve opening. So during early rapid filling, pressure is higher in the atrium and lower in the ventricle. This is caused by LV relaxation, and this gradient causes mitral valve flow, the E wave. The greater the gradient, the greater the flow. And this ends, as I said, after the first third of diastole. The third phase is called, here in orange, diastasis, from the Greek diastasis, which means separation, because it separates the second phase, early rapid filling, from the fourth phase, which is caused by atrial contraction, here in red. This determines minor left ventricular filling, as you can see here from the minor increase in the LV volume curve. Pressure in the ventricle and the atria at this point usually overlap, so that essentially in this phase, since the gradient between the atrium and the ventricle is small, the filling of the ventricle usually occurs because left ventricular compliance is higher than left atrial compliance, so the blood tends to enter the ventricle. The fourth and final phase in red is atrial filling, caused by atrial contraction. This completes LV volume, so we reach at this point, it starts with atrial contraction. You can see it produces the transmitral pulse Doppler A wave, causes an increase in atrial and ventricular pressure, and ends when isovolumic contraction starts, which closes the mitral valve. So it is evident that in a healthy, normal heart, the majority of LV filling, up to 80% or more, occurs during the first third of diastole during LV relaxation. Atrial contraction in a normal heart contributes to 5-15% of filling, and usually the more bradycardic the heart, the less the filling. In contrast, when we have grade 1 diastolic dysfunction, that we will see in a minute, where relaxation is prolonged and filling during early rapid filling decreases, atrial contraction is more important. There is a shift of filling from the early rapid filling to atrial contraction. And in extreme cases of LV prolongation of relaxation, most of filling occurs during atrial contraction. And finally, when we have the most severe grades of diastolic dysfunction, grades 2 to 4, most of filling is shifted back to early rapid filling and is driven by the very high filling pressures. Okay, so let's carry on with physiopathology. The left ventricular pressure volume loop, which is the basis of diastole. Here the slide is quite complex, but again, this is basic cardiac physiopathology. You cannot think of performing analysis of diastolic function with echocardiography if you don't first analyze, comprehend all of this. It's necessary for the understanding. So we're going to analyze the LV pressure volume loop. In A here, let me stop. There's the representation of the left ventricular pressure volume loop during the cardiac cycle. This is obtained, the one that I show you here, by introducing in the LV cavity a conductance catheter, which has also pressure transducers that measure intracavitary pressure. And here you can see that we have the LV volume measured by the conductance catheter during the different cardiac cycles, and here we have LV pressure. In this case, by representing both volume and pressure on this Cartesian graph, and by putting volume on the horizontal axis and pressure on the vertical axis, we create a loop. And below the LV pressure tracing here is the LV dP on dt, which is the first derivative of the pressure curve. And this first derivative has two peaks. The first one in red during isovolumic contraction and the rapid rise of pressure, and the second here in red during the rapid decrease during isovolumic relaxation. We'll come back to these in a minute. The pressure volume loop has 4 phases: 1, 2, 3, and 4. Oh, I'm sorry. 1, 2, 3, and 4. We start at end diastole with mitral valve closure, MC, which is caused by LV contraction and rapid rise in ventricular pressure here. 1, between mitral valve closure and aortic valve opening. This is isovolumic contraction, and this we have a rapid increase in pressure with substantially invariant LV volume, and ends with the aortic valve opens. During this phase, we have the positive, in red here, peak of dPdt, which is a measure which is used to measure contractility when we measure this as a gold standard with cardiac catheterization. dPdt is not really the main gold standard of contractility because it is load dependent, but it is usually commonly used during cardiac catheterization to measure LV contractility. The second phase of the loop here is ejection, which begins at aortic valve opening, A-O, and ends at aortic valve closure, AC here, during ongoing myocardial contraction. During this phase, the left volume here, the left volume decreases and pressure slightly increases between beginning to the end of ejection. The first phase here, third phase here, is isovolumic relaxation, which begins at aortic valve closure. We just seen that on the previous slides, and ends at mitral valve opening. During this phase, LV pressure abruptly falls as commanded by LV relaxation, and there is no significant change in LV volume. During this phase of isovolumic relaxation, we have the negative dP on dt here of the pressure curve on green here, this negative peak, which is the invasive measurement most used for relaxation during cardiac catheterization. It is load dependent, also this one is load dependent, but is commonly used to measure invasively LV relaxation. Another measure of relaxation during this phase is tau, which is a time parameter related to the decay of pressure during the isovolumic relaxation. The fourth phase here, down here, is the ventricular filling, which begins at mitral valve opening, MO, and ends at mitral valve closure, MC. During this phase, there is a rapid increase in ventricular volume, as you can see here, with a minor increase in pressure, as you can see here. From here, minor increase in pressure. In this pressure volume loop in the graph here in B, again, you see the pressure volume loop, and you can see the diastolic fourth phase of the loop here filling, and you can see the minimal increase in pressure during volume increase of the ventricle during the first third of diastole and mid filling, and a mild increase during end diastole and atrial contraction. Okay, here where you see in B. As you can see here, the diastolic pressure volume curve is exponential, but still rather flat on the horizontal axis. So we have seen how we measure invasively relaxation during catheterization using negative dP on dt or tau, and both measurements are done during the isovolumic relaxation phase. And these measurements, dP on dt and tau, are the gold standard to which we relate the measurements of relaxation with echocardiography, the E wave, the E prime wave. We'll see that shortly. But how do we measure invasively ventricular compliance? And what is exactly ventricular compliance? In the graph here in B, on the right, you can see the white closed pressure volume loop of one cardiac cycle. We have pressure on the vertical axis, as we have said, and volume on the horizontal axis. The diastolic pressure volume diastolic curve is shown down here. The upwards and leftwards shift of this diastolic curve, which is represented by the red line, points to a reduction of LV compliance or increase in stiffness. And this movement of the curve upwards and to the left can be measured by a constant which is called K. As you can see, when compliance is reduced and the pressure volume curve is up here, for the same volume here in A, pressure will be higher. Same for, this is in mid-diastole and this in diastole. So same volume in B in a normal ventricle, when compliance is reduced, the pressure will be much higher. So the effect of a reduction in LV compliance will be to increase the filling pressure for the same LV volume. This will also be followed by a secondary increase in left atrial pressure. This somewhat complex framework is our reference as cardiologists, as non-invasive cardiologists, for all our measurements of diastolic function and dysfunction with echocardiography and pulse Doppler echocardiography. So it is essential to learn these mechanisms, or we will be never able to truly understand what is going on in our array of echocardiographic measurements. What we are doing with our echocardiographic measurements is to try to estimate by approximation the invasive parameters. So the constant of compliance K, dP, negative dP on dt, and tau. And to which, if they are abnormal, and to which extent they are abnormal. So if relaxation is normal or abnormal, and if it is abnormal, to which extent it is abnormal. And of course also to determine, to estimate the filling pressures. This is the end of video number 1. Please proceed to video number 2, from estimation of left ventricular filling pressures to current recommendations. See you on the next video.